and welcome this evening to Maternity and Midwifery Hour. And my name's Sue MacDonald. I'm the curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals. And it's my pleasure to be chairing the session this evening. And tonight is actually week 10 of the 16th series of Maternity Hour, which is a bit amazing. More about that later. And I'm delighted to be welcoming three lovely speakers. I have Christina McCourt, I have Georgia Clancy, and Shireen Patel. And just because we always do this to our speakers, I'm going to ask them if they'll share a moment of the week. And I think I'll start with Shireen, please. Your moment of the week.
Right, thanks, Sue. So my moment of the week, I think it's got to be painting our fence. And the reason I think it's a moment of the week is it was an achievement. It took us 2 days. We did it over the weekend when it was really hot. So it
Oh,
was not easy, but we kept going. There was a lot of body pain at the end. But seeing the result now, it was definitely worth the pain. And like I said, I feel very happy that it's finally done. So yeah,
wow.
that's got to be my moment of the week this week.
That is an achievement in the heat that we've had. And I suspect there might have been some body paint as
Yes,
well as the pain.
yes, definitely.
Unless you're tidier than me when you're painting.
Yes,
That's fantastic. Thank you, Shireen, for
no,
sharing that. That's lovely.
no problem.
Now, how about Christine? Have you got a nice moment? I think you have got a nice moment of the week to share.
Well, it's a special moment, I think. Today would have been my mum's 100th birthday. And it's also 20 years today since my mum died.
Oh gosh,
So
that's
it's
special.
a special moment.
Yeah. Because when we've lost our mums, we always remember them every day. But this is a very special 100th
Yeah.
birthday. A happy heavenly birthday, Christine's mum. That's lovely. Thank you for sharing that. It's very special. And Georgia, your moment of the week for us.
Mine was very simple. Mine was just yesterday. I was in the office, and me and some colleagues went outside and had our lunch outside, and we got ice creams in the sun, and we sat on the grass, and we made use of the lovely vitamin D that was shining down on us, and it was just a nice little pause from work
Gosh.
and a little treat as well.
And that's perfect to do. I think we need to actually, I think these are all lovely moments. And I think that is about caring for yourself as well. Actually, they're all about caring for yourself because we've had body pain and we've had heart there from Christine and we've had looking after yourself with an ice cream. So thank you so much for sharing those moments. Now I'm going to let our presenters have a little break. And I know that there's new people here tonight. So welcome to all of you. You might not know the birth of the Maternity Midwifery Hour. I know that our old friends do. We've been doing this for 5 years. I can't believe it's 5 years, but it is. And we started in March 2020 with the onset of the first UK lockdown for COVID. And it was a time where we really wanted to make sure that midwives and student midwives and anyone actually in the maternity services could have a connection and could get a source of information and continuing professional development. So we started just doing an hour. We did a lot of stuff around COVID and the changes in maternity services and midwifery education at the time. And there were a lot of changes that had to be made. And that you'll remember how scary it was and how uncertain things were while we were all trying to get through it. And we got through it. So good luck. Yeah, we did brilliantly well. But since then, we've carried on. It seems as though people still want this hourly session, not hourly session, that would be a little bit much, weekly hour session. But we've changed what we do. So we sort of trawl around for really interesting things and things that are very appropriate to us as midwives and student midwives and maternity services generally. So the other thing I need to say is that all the things we do are recorded. Everything the Maternity Midwifery Forum does is recorded, including the maternity and midwifery festivals. And that so if there's any problem, we always have the recording. And that means that if you have a power cut tonight, don't panic because you can get the recording and that'll be available after this evening as well, and on a podcast at 6 o'clock in the morning on Friday, which is, I know a lot of people like as well. It's useful. It's looked after by our Matflix colleagues, and it means that you can access a whole lot of information, very contemporary, useful information, some of which we go into box sets, which Dr. Jenny Hall pulls together with lots of reflective activities and things. Very good if you've got a topic that you really want to immerse yourself in. Or if you have a project or a dissertation that you're working on, this is the place to access it. So the information on that is on your resource sheet. And your resource sheet this week has got lots of bits and pieces on it that will be useful, and that's included. And so that's very good for sharing as well. So I know you're going to really enjoy this evening's session, and I think you might want to share with other colleagues. And if you don't, you should. So afterwards, please do share, because we like you to share the things. We're not precious. We don't lock it up. And it does help make you understand maybe things when you're describing it to other people, having a discussion and showing them the clip. It really does help put it in your brain and make you think slightly differently and add to your learning. So that's that. Now, moving on swiftly onto the news. Now, tomorrow is the launch of the 10-year NHS plan. I know we've had some information, I think it was a weekend now, about getting the nation healthier eating and weight control and all that sort of thing, and additional mental health workers being recruited alongside £120 million for mental health emergency, more for GPs and dentists, and technology. I'm waiting to see if there's a little bit more about getting additional midwives and nurses, because I think I have a personal interest in that, as I know many of you will have. So we'll just have to see. Now, I'll also say that on the 5th of July, it's the UK NHS UK's 77th birthday. So little celebration there for us all to celebrate the good things that we have in the NHS, and we have a lot of good things, and I think it's important to do so. Also, I need to highlight that there are updated NICE, and that's National Institute for Care and Health Excellence, intrapartum guidelines. They actually were published in 2023, but they've been updated in June. So it's worth just checking out that you're using the most updated copy. Now, awareness days and awareness weeks. This is Group B Strep Awareness Week. This from the 8th, actually, it was next week, 8th to 14th of July. And I've put the link to the Group Strep B support website on the resources sheet. And also today it is National Bereaved Parents Day, which is a kind, we know that's a very sad day, and you'll notice there's a little candle in the corner of the screen that's honouring that, and I've got a little candle behind me. You probably can't see it with all the other nonsense I've got there, but it's an important day for thinking about the impact of the loss of a child at any age and any cause. And there are resources on the resources sheet. And now I'm going on to almost perfect timing here. It was Research Appreciation Day yesterday. Now, we know we shouldn't have just one day for research appreciation. And I know my three speakers here won't just have one day, because they eat, live and breathe research, and it's a very important part of their lives. And we're looking at research, and I was thinking about this over the last few days and thinking it's one of the key things for researchers is getting research out of bits of paper into practice and improving care and services for people, whatever is being researched. And that's one of our key objectives. And one of our things is to get great care for mothers, babies and families, to get them safe and compassionate care. And there's been a huge concern over the last few years about the disparities between care, particularly maternity, for Black and brown women versus white women. And it's really important that we ensure their voices are heard, and also they're represented in the research that is carried out. So we've got two projects this evening that I think highlight some of the challenges and some of the important things that we can get out as midwives both as researchers, but as consumers of research, really important. So they've got this at their heart. And I also must say, I'm not going to read the whole CV for our speakers. I'm just doing sort of short headlines because their CVs are online and I don't want to take anything from their presentation. I want as much time as possible. So firstly, I'm delighted to welcome Professor Christine McCourt. She's Professor of Maternal and Child Health, School of Health and Medical Sciences, and she leads the Centre for Research in Maternal and Child Health. She teaches at undergrad, master's and doctoral level, as well as conducting and support. Actually, it says huge range of research projects. Her key interests are in maternity and women's health, with particular interest in institutions and service change and reform, on women's experiences of childbirth and maternity care, and in the culture and organisation of maternity care. I know that she's been poorly, but she's here and looks fantastic, and I know is going to do a fantastic session. And welcome, Christine, and thank you so much for coming this evening. The screen is now yours. I should have said that.
Okay. I'll just share screen. Hope things go smoothly. As Sue said, I'm not feeling my best today, so hopefully I'll stay on top of things. Okay. Is that visible okay to everybody?
Just needs full. Just needs.
Yeah. Okay. Lovely. All right. I'll begin. And Sue, I hope I don't talk for too long. Hopefully I will talk less than usual because I usually have too much to say. Okay. So I'm going to share with you a little bit of our research experience from this project. And I have to thank the colleagues in the team who worked on this. Sidera was one of our master students who worked with us on the project. Octavia did a lot of the work on the actual running and the implementation of the care and the running of the trial, and also not mentioned. No, that's the first slide. Okay, I'm seeing the first slide. Can you just tell me what it says on the slide that you can see? Oh, right. Okay. Okay, so apologies, folks. We don't know what happened there. Some strange movements in the slides. Hopefully, we're back at the beginning now. Um, so I'm not sure where we were cut off to fix the slides, but I'm going to share with you our experience from the Reach pregnancy program. And Sue was talking before about how we do research because we want to improve quality of health and service experience. And that's very much kind of captures the aims of the Reach pregnancy program. Um, we it wasn't part of our original aim to publish something methodological on how to recruit underrepresented groups in maternity research, but our experience was quite interesting, and so we thought it would be useful to share it with people and to publish it. Okay, so next slide, please. Okay, so the overall aim of the programme was to improve access to good quality maternity care and, really beginning to address the kind of inequalities that Sue had mentioned. Next slide, please. I'm going to come on to how we did the program, the kind of shape of things in a moment, but just jumping ahead slightly for a moment, I'm going to talk about the Pregnancy Circles trial. So this is a trial which is not looking at so much at a clinical intervention as a model of care, a whole approach to how to provide antenatal care. And this is something that came out of the community-based co-design work that we'd undertaken before the trial. So I'm going to kind of introduce you to that very briefly in a moment. But first of all, what is this model of care? Some of you might have heard of it. It's been tried a lot in the US and now in a wide range of countries globally. There had been a small pilot study in the UK previously. I can hear an echo. I'm not sure what's happening there. Okay, I'll carry on speaking. I've got a little bit of echo there, and it had been piloted at King's previously and had not been continued. And really, out of our co-design work came the idea that this model of care might be useful to address inequalities of access and improve people's experience of care at the very least. So, next slide, please. Okay, so this slide just shows you a bit of a very quick overview of the shape of the research. One of the issues I think that forms a challenge rather than a barrier for really good inclusion in research is time. Not just budgets, but time. Research projects often have to be done quite quickly. We had the privilege of having quite a long time window for this study. I mean, actually, COVID added 2.5 years to it, but it was intended to be a 5-year program with some previous exploratory work. So you can see there that we started with really kind of community-based co-design. Out of that, the idea for a couple of interventions, including the pregnancy circles, emerged. And we then did an initial qualitative feasibility study to see, can this be done in the NHS? It's not been, not been trialed so much before, and how can it be done? That was then followed up by a pilot trial and then a full trial. And if you can just click on one. If you can move us forward one. Thank you. Okay. So what I'm going to talk about is phase 2. First of all, when we did some test groups to see if it was actually feasible for us to even run a pilot trial. And then if you can click on again. Thank you. And then I'm going to compare that with our experience in the pilot trial. So between the feasibility work and the pilot trial, we put in place some measures to try to improve diversity of inclusion. And that's what I'm going to carry on talking about now for the rest of the presentation. Thank you. Next slide. Okay, so as Sue has alluded to, we know that women from socio-economically disadvantaged or racialized groups tend to have more negative experiences of care. They also have higher rates of non-attendance, and they're experiencing worse maternal and neonatal health outcomes. So these are the kind of problems that we were wanting to address. Now, given that focus in the program, it was very important for us to actually make sure that we had sufficient diversity in our research program. It was intended to address these kind of questions, and we knew from experience that many trials do not include a wide diversity of people for various reasons. So we were kind of mindful of it right from the start, and we learned a certain amount from the feasibility work. Okay, if you can move on, please. Thanks. Okay, so yeah, if you can go to the next slide, thank you. So what did we already know? We know that there's systematic bias amongst researchers themselves. They might be less likely to think about how to include people. They might assume that certain people aren't going to be interested and so on. There are budget issues. I've been involved more peripherally in trials where women who didn't speak English were simply excluded because there wasn't money for interpreting services, for example. Okay, and the next bullet point, please. Lack of familiarity with research, need to actually go out there and kind of make the contact with people and make them feel comfortable and familiar with the research. We were already aware that this could be an issue as well. And next bullet point, please. And then also practical issues. You know, it's easy to assume if you have a more flexible and comfortable life that it's easy to take part in research, but it's going to be more difficult for some people than others. So we already had ideas about what might be difficult, but we wanted to learn more and make sure that we did as good a job as we could. Okay, next slide, please. Oh, yes, and the last point, I just missed that bullet point there. Lack of trust, I think, is an issue as well, at least for some communities. Is there a kind of feeling of trust that would encourage people to actually take part in research? There has been a history for some communities of exploitative or covert research, which has damaged trust in health research as well. Not so much in the UK, but in the US, that's been a very big issue. So we were aware of that issue as well. So we wanted to kind of learn more about all those kind of things. Next slide, please. Okay, so our feasibility study, we wanted to try out 3 circles, see how it went. This was based in an inner city service that had a very diverse population, both ethnically and socioeconomically. Okay, next bullet point, please. We made sure that our inclusion criteria were very wide. Sorry, I have a bad cold, so I'm a little bit croaky. Some of the previous studies of group care in other countries had used quite narrow criteria. And one of the things that we learned in our feasibility work was that women in local communities really wanted the groups to be diverse. They valued the idea of group antenatal care being a way to meet others in their community and get support from other people from a range of backgrounds. So we really were wanting to go for diversity rather than more specialized groups. Okay, next bullet, please. We knew that we would need to fund interpreters in the circles themselves. So for us, there was a kind of double level to everything. We needed to make sure we paid attention to the recruitment, but also it then had to flow through to the model of care itself. Next bullet point, please. The women were offered a £10 voucher for taking part in surveys or interviews, really as a compensation for their time, but we didn't think that that was going to be, the most important or the only issue. There were other issues that we wanted to address. Next bullet point, please. Okay, and to see how we were doing, we measured ethnicity, the level of English proficiency, of the participants, and that of course includes all the people who were approached and their educational level, so that we could track how well it was going in terms of recruitment, as well as what was affecting that recruitment, both kind of in research terms and in terms of whether this model of care was going to work for a wide range of people. Next slide, please. Okay, so how did it go? We had a good representation across different ethnic groups. That worked well. That was a relief because it was in a very ethnically diverse area, so it should have been. Okay, next bullet point. So we recruited 24 women, 63% of them were born outside the UK. So that is, I think it's a much better statistic than many studies. And we had a good range of ethnicities. And for this kind of thing, also, I think a pretty standard rate of agreement to take part. So that all looked very encouraging. Okay, next bullet point, please. There's the but. However, when we looked at educational level, we found that the majority of our participants were highly educated, so we weren't getting quite the diversity that we had initially seen. Okay, next bullet point, please. Okay, and also in terms of language diversity, although many of the women were not UK born, all of them said that they spoke English well or very well. And that's in a situation where we had thought in advance about provision of interpreters for the model of care as well. Okay, so we knew that there were areas where we were doing okay and areas where we needed to improve. So we wanted to put in place some measures to improve that. Next slide, please. Thank you. So for the pilot trial, we wanted to increase, in order to test the feasibility of a larger trial, we wanted to recruit around 72 women. Obviously, that's randomization across 2 groups, running 3 circles. Okay, next bullet point, please. Sorry, this is a little bit slower because I can't control the movement myself. So we had 3 inner city maternity services. Next bullet point. And one of the great assets for the pilot trial was the fact that these services had bilingual health advocates. So these are people who are more than just an interpreter. They come from the local community. They act more as cultural mediators as well as interpreters, and they're actually embedded within the service. And one of the things that was very interesting from my perspective when we approached the service about being involved in the trial and with this model of care was that they really welcomed the opportunity to be actively involved, and they liked the idea of continuity with the group care schedules, because they have the challenging situation often in maternity of being called in on the spot to do this, whereas this model was actually giving them the opportunity to work with a group of women, get to know them, and kind of progress through. You know, they had all those continuity benefits as well. So they were very enthusiastic about it. Okay, next bullet point. We did have to fund the additional time for the interpreting for recruitment and for the bilingual health advocates. And I think there's a lesson there. I'm sure I'm going to say it again at the end, but very often when budgeting takes place for studies, the budgeting is quite tight and people don't necessarily allow a lot for these kind of levels of activities to make sure that the study is really inclusive. So we needed it to be there in the service, but we also needed it for the recruitment, and it wasn't routinely there. So we actually had to fund that as an additional cost rather than something that was just funded through the Clinical Research Network, through the NIHR portfolio. Okay, next bullet point, please. We had quite a range of languages in our own centre, which was very useful, but you can't rely on that. But we made use of bilingual research staff as much as we could, particularly for interviewing. Okay, next bullet point. And another thing that we'd realised in terms of recruitment of women, a wider range of women, was that we might have been missing women who booked a little bit later. So we widened our recruitment period and had another recruitment session at the ultrasound scan at 20 weeks. And that helped to bring in women who might have been missed out because of later booking otherwise. Okay, next bullet point, please. Okay, and then I suppose there were two layers to the training with the midwives. On the one hand, we had to provide training for the midwives who were going to facilitate the circles. This was very new to them. And also we were asking them to run groups that were quite diverse in terms of first baby, subsequent babies, different levels of risk, different languages potentially, no more than two, but different languages nonetheless, and people from a diversity of backgrounds. So the midwives needed to kind of skill themselves up there as well. But also we needed to put some work in to the research midwives who were doing the recruitment, because we found that in practice they hadn't had much opportunity to develop expertise in recruiting a wide diversity of people. Okay, next bullet point, please. We also were aware from the feasibility work that ideally we should be able to have creches for the intervention. Now that's a particular thing I think to do with our trial, because we were looking at group care, which is a much longer session. And I'll come on to the data about that in a moment. Okay, next slide, please. Okay, so again, this time we looked at parity, ethnicity, educational level and English proficiency. And we asked those who declined, very kind of making it clear that this is about us learning, not you having to justify why you didn't want to take part, but we can learn from you if you don't mind spending 5 minutes having a quick chat about this. So an anonymous survey, which they could fill themselves or could be filled for them to help us to understand the reasons for declining, so we could learn more to feed into the full trial. Okay, next slide, please. Okay, so what did we end up with? This is just a quick overview, and you can see there that these measures did actually help to improve things. So as I said, with the feasibility study, we actually had quite good diversity in terms of ethnicity, but not in terms of education and not in terms of language. Parity was pretty okay in both cases. So we saw an improvement there in terms of English, and quite likely that was down to having had the interpreting at the recruitment, and in terms of educational level as well. So it did show that the additional measures that we put in did seem to make a difference. So this was in the same area. Okay, next slide, please. Oh, that's just highlighting what I've already said. Okay, and then if we just do a comparison there of those who participated and those who declined, we were able to use these very quick surveys to get a sense of whether there was any pattern to people saying yes or saying no. And you can see there that there was still more likely to decline if you didn't speak fluent English, and a little bit more likely to decline if you had babies before. And I'll say a little bit more about that in a moment. But certainly an improvement in terms of language on the feasibility work. Next slide, please. Okay, so this wheel shows the kind of reasons for declining. This was very informative for us. So we learned that a lot of the problems were actually practical ones to do with the model of care and how we needed to make the model of care more accessible. And it was interesting that it didn't match very well with what some of the more senior people, not the frontline midwives, but some of the more senior people had said to us when we did our initial feasibility interviews, oh, women from certain backgrounds are unlikely to want group care. So there was a tendency to possibly slightly protective steering going on there, thinking that certain people in your community won't be interested in something rather than really going and finding out. And actually, it just was not very common for women to decline on the basis that they didn't like the idea of a group and privacy and so on. This was relatively uncommon, just a few. It was more often childcare issues, work issues, because of the 2-hour sessions. Women who were in more insecure occupations were worried about the reality of being able to get time off work. And then also the midwives had great difficulty in accessing community venues. Many had been closed, in a period of austerity. And also, despite, what might come out tomorrow in the NHS 10-year plan, a lot of divisions between health and social care, cross-charging and so on. So the midwives struggled to get accessible community venues for the pilot trial. So, okay, next slide, please. What did we find? I'm just going to try and sum up. So the women who had a lower educational level were more likely to decline because of practical issues, caring for young children and lack of childcare, actually more than work issues. Next bullet point, please. And then the women from a white background were more likely to cite insecure work and difficulty getting time off work as a reason to decline. And that might reflect the local kind of profile of the local community in that area as well. So it's not necessarily totally transferable to everywhere. Next bullet point, please. This is an area with a very high Bangladeshi population. And a lot of the women cited caring responsibilities as a key reason for declining. So that was important for our area. It might be a little bit different in some other areas. Next bullet point, please. Only one woman declined citing language problems. And it did seem to be more practical issues that were driving that. But this, I think, is because we'd done a lot of work to put proper language support in place. And as I was saying before, that is not as routine and common in trials as you might hope and think it is. Okay, next point, please. Okay, and the next slide. So key points about how we could have improved in recruitment further. Clearly providing provision for childcare for a study like this, which wasn't, a drug trial, it was more a time commitment for the women, would have made the most difference, we think. Better access for the midwives, better integration of midwives with community services would have helped enormously. Challenging the women's assumptions about this model of care. It was interesting that when we did our PPI work initially, the women who'd had a baby before tended to say, what you don't know when you haven't had a baby before is that you may spend 2 hours because you wait ages in the clinic and then you have a really quick visit. So, take this into account. But if you're having your first baby, that may be less clear as well. Okay, and the next slide. So, as I've mentioned, we can't automatically transfer these findings to other areas because you might have a different population profile in the area where you were doing a trial. One of the things that just didn't come up for us, for example, was lack of trust in health research. And I know from experience working in other trials in this area that the level of trust in health professionals and health research in the kind of North and East London community where we were doing this work is high. but it could be a big issue in other areas. So that's not something that our study touched on, but may be important. I think there's a key lesson there about how clinical research networks are actually designed and resourced, because the default model, I think, this is me inferring from our experience in this trial and other trials, the default model is of a much simpler interventional trial, usually something modeled more like a specific treatment, a drug treatment, where recruitment can be very quick. This is quite a complex model of care. The research midwives needed to take time to explain it. And then if you need interpreting as well, you need to allow extra time. So inclusion takes time, and that really needs to be built into the system. So I think, we have a lot of good intentions and a long way to go. The other thing that we did experience was unconscious bias. I think it wasn't a big issue later on in our experience, because we did a lot of work with the research midwives to try to kind of get across the importance of diversity in these groups, that this was really important for our study focus. And please don't try to decide who's relevant to approach or not, but I think it's something that they get used to doing. So there's always the issue of trying to counter gatekeeping that's well intended but may actually inadvertently exclude some people. I've mentioned also the impact of austerity in terms of closure and withdrawal of community services. That made this kind of trial more difficult, not least the fact that by the time we started the full trial, the bilingual health advocacy service had been withdrawn from the service, and the services were tending to rely on telephone interpreting, which isn't the same. And obviously, we're talking about a complex intervention here, highly complex intervention. That's pretty typical for midwifery. So that lesson about how much time and resource needs to be built in, I think, is something that we need to keep feeding back to clinical research networks and funders and so on. Okay, and I think I've got the last slide now. Just a few recommendations from our experience. So try and make sure that you write these things into your design. Think about how the service might shape it. Think about language and how you're going to cater for that. Think about caring responsibilities, particularly when you're involving mothers of young children in research, and also the impact of insecure working conditions on people in more disadvantaged population groups. Next bullet point, please. Okay, and the importance of engagement. We had the privilege of having a lot of time to do engagement and talk to people. Wherever possible, try to build it in to what you're doing. Take your time to build a project. It's really, really worth it to do that initial engagement by whatever means you can. And that's it. Thank you.
So much, Christine. I think that's fascinating. And I think the pregnancies that I have to say that there's a very good publication which gives lots and lots of information, which is on the resources list. But also I was quite interested by you saying the concept of pregnancy circles one, because what I was thinking, you brought the time right at the beginning and round to the end as well, and that really did illustrate the kind of some of the constraints that affect the research and the researchers. So thank you so much for setting the scene with that, and giving our audience some thoughts and some questions. We are running a little bit late because of our technical issues, but don't worry, we've still got Georgia to come, and some time for questions if you have any. So any audience questions, just pop them into the chat box and Paul will send them through to us. So I'm going to swiftly let Christine get her breath back and sort her poor throat. And well done for keeping your voice going all that time, Christine. And I'm going to say a huge welcome to Dr. Georgia Clancy, who's a social scientist at the University of Nottingham, and her research focuses on maternity care services and experiences, in particular inequalities, digitalisation, and choice and risk in childbirth. And she's currently the lead researcher on the PROMISE study, which seeks to develop guidance for increasing the representation of Black women in maternal and neonatal research. And she will be joined by Shireen Patel, Dr. Shireen Patel, who's in the kind of background for this until the questions at the end, who is a research fellow at the University of Nottingham with a particular interest in reducing inequalities by enhancing accessibility of mental health services for marginalised groups and engaging underserved populations in research. She is a strong advocate for involving and collaborating with patient and public involvement and engagement, PPI/E. Representation in research. And welcome. The screen is now yours. And thank you for coming, I should say.
Kind of will provide a brief introduction to the PROMISE study, which we created for International Clinical Trials Day, which was a couple of months ago in May. And that will just show you a bit more about the project and also the rest of the team who are involved as well. We can.
Black mothers and babies have poorer outcomes than white counterparts. That's a fact.
Did you know Black women are 4 times more likely to face severe health complications during childbirth compared to their white counterparts? Right here, right now in the UK.
As a researcher, every year on May the 20th, we celebrate International Clinical Trials Day. And this is where we honour the power of clinical trials to transform the lives of many people. However, not everybody participates equally in clinical trials. And in the UK, Black women are significantly underrepresented, particularly in maternal and neonatal healthcare research.
The PROMISE study aims to change this by working directly with Black mothers, midwives, researchers and community groups to create clear, culturally sensitive guidelines that help researchers build trust, authentic communication and ensures Black women are fully informed and included.
So if you know anyone who's about to give birth, pregnant, just had a baby or have small children, we want to hear from you.
We want to empower the healthcare staff to have culturally sensitive and appropriate conversations with Black women so they can make informed decisions as to whether they'd like to take part in a research opportunity. It is hoped that by doing so, more women will choose to be involved in this research.
This work is a critical step towards fairer, safer and more effective maternal health care for all families.
Great, thank you for that. Hopefully that provided a sort of brief introduction to PROMISE and the rest of the study team as well. So today we are just going to be presenting preliminary findings. We're still in quite early days of the PROMISE study. It's only started a couple of months ago, so we are right at the beginning. But hopefully, yeah, we can give you a bit of a sort of flavour of where we've got to so far. So I'll give a little bit of background, which I think some of it's sort of come up already with Sue and in Christine's sort of what they've been talking about as well. So PROMISE stands for Principles of Engagement, Developing Methods to Increase Representation of Black Mothers in Maternal and Neonatal Healthcare Research. And this project really came about in response to the inequalities that I'm sure many of us are aware of, which are kind of persistent in maternity care, particularly the racial inequalities that Black women experience linked to their race and social deprivation. So these are probably statistics that people are well aware of, that, you know, Black women in the UK are 4 times more likely to die in childbirth than a white woman. And that's often linked to pre-existing conditions and also comorbidities, issues around mental health, health injustices that exist in our society. And that inequality also manifests with Black babies as well, who have the highest stillbirth rate in the UK, again, linked to other healthcare factors. So we know that this is a big issue. We know this is a pressing issue, and the NHS is trying to tackle these health inequalities and has made this a kind of key area and a mission. But part of thinking about how we address those inequalities is thinking about getting more Black women involved in maternity and neonatal research so that we can understand more about their experiences, more about their bodies, and design interventions which are more personalised and better suited to their needs. So understanding the barriers that they face, and also thinking about the processes at which we recruit women to research. So research delivery teams are often the people kind of on the face of research. For many women, they'll be the midwives or the doctors, the nurses recruiting, often, you know, in hospitals or in GP clinics. They're sort of the face of many research studies, particularly clinical trials. And so understanding that relationship and how those staff members can be best supported to recruit Black women to research. And the goal of Promise is kind of to try and think about how we can co-develop guidelines to improve this inclusivity. So the project team is multifaceted. So I'm Dr. Georgia Clancy, I'm the lead researcher. And then I'm based at the University of Nottingham in the clinical trials unit with one of the co-principal investigators, Dr. Sophie Hall. There's also Professor Kathy Henschel, who is a professor of nursing at Oxford Brookes University. And then our co-investigators, Dr. Shireen Patel, who is here as well, also based at Nottingham. And Bhuvan, who is based with Equality Health, who are kind of our community partner, who are helping to connect us with community organisations and make sure that the work that we're producing is really grounded in stakeholder engagement, co-design, and understanding the needs of the communities most affected. So we've got this broader study advisory group, which is made up of different national figures in maternity care, midwives, doctors, people who are specialising in race and equality in healthcare, and also of diverse PPI groups. So that's women who have recently given birth or are currently pregnant, also healthcare professionals, and also different community organisations as well. So Black Mamas Birth Village, Black Health Initiative, and Research Black are all supporting the project, again, to support access to those communities and make sure that the work is relevant and practical. So the study aim is thinking about how we can support these research delivery teams. So these people who are on the front line of recruiting women to research and thinking about how they can engage Black women better in maternity and neonatal research in particular. So as I said, this is kind of a timeline of where we are with the project so far. It's just a 12-month project. We are about 4 months in. And so far we have conducted our systematic review, which has been quite an extensive review. I'll say a bit more about it in a minute. So that's looking at the existing literature to try and understand the different cultural, environmental, social factors that Black women face with regards to recruitment and retainment in healthcare research. We are currently in the middle of our focus groups. So we've just recently finished our focus groups with healthcare professionals, mainly research midwives took part in those. And tomorrow we're very excited. We're going to be starting our focus groups with women, and so women who have recently given birth or are currently pregnant. And so we're really excited to start collecting that data as well, and speak to women about their experiences. And then the rest of the project, as we continue to move through it, will be there'll be more PPI because we want this to be a kind of co-developed set of guidelines. So there's an extensive process of PPI meetings and consensus workshops in order for us to develop these guidelines, principles of engagement, which we hope will be really useful for staff members. Oh, super. So the systematic review, as I was saying, we've just recently finished this. We're still working through some of the data, but it was a huge sample of papers. We had nearly 4,000 papers returned when we ran our review search, and through screening and our inclusion exclusion criteria, we've whittled that down to 62 papers, which is still quite a lot of papers, which we've now finished reading and extracting data from. Some of the things that are quite interesting is that the vast majority of that data has come from the US. So we're thinking about this research, we're looking at kind of global patterns, but also thinking about how it will specifically relate to the UK context. And so it's interesting that most of the data is coming from the US, and thinking about that sort of transferability to the UK will be an interesting challenge, I think. So this is a sort of preliminary view of our findings so far. We're kind of currently playing around with different ways of thinking about and presenting this data. And this model here kind of looks at the different contexts and key themes from the review, and how the themes kind of cut across different contexts. So starting at the kind of individual level, which is thinking about beliefs and motivators and barriers. So that can often be like people's personal connection to a condition. That might be a key motivator for them, or not, if they feel that they don't know anything about a particular healthcare condition. They can also often around fears, around taking part in research. Sometimes that can be linked to kind of concerns about exploitation, and particularly, as Christine was saying, again, because this data is from the US, there's often sort of historical narratives there that people are drawing on because of previous injustices which have occurred in healthcare settings against Black people in particular. Although, as Christine was saying, that's not been as prevalent in the UK. But that's sort of obviously what's coming through in the data, because the data is mainly from the US. And then there's also issues here around healthcare literacy, and also people's sort of research literacy as well, whether research is something they're familiar with and how it works, and thinking about the convenience of taking part as well. And then we can move up into the interpersonal level. So that's thinking about personal relationships between women and healthcare professionals or research delivery teams, whether they have trust in those individuals, whether those teams are diverse, because often what comes through in the data is that people want to see people like them, working in healthcare, working in research teams, to see that there is that commitment to diversity, particularly if people are trying to do research around diversity. And that's often referred to as kind of researcher participant concordance. So thinking about the sort of similarities between the participant and the researcher or the healthcare professional. And also in this interpersonal context is thinking about the support of family and friends and wider communities as well. Often in the data, there's a lot of emphasis on women wanting to discuss their decisions with their community and their friends and family, and needing time to do that. And then we move up into the research operations. So that's thinking about the more kind of practical issues, things about, accessible materials, ethical processes, how the research is designed, if that design is appealing. So, often people are more happy to take part in non-invasive research, things which are more sort of about experiences or behavioral research, rather than taking drugs, having an intervention, some kind of procedure. And also thinking about how research organizations are engaging with communities in really meaningful ways. Often it seems that there's a perception that community engagement can be quite superficial, sort of researchers flying in, taking the data they kind of want and flying out again without really building those relationships, sharing things about themselves with those communities, showing that there is investment, and and also really importantly, coming back and sharing findings so that those communities feel like they're getting some benefit from the research and aren't just kind of being used as an information source, but not ever really seeing the benefits of that. And then the final context is thinking about societal and structural issues. So that can be like the political climate and sort of wider social issues of trust, kind of institutionally. So it might be linked not just to kind of mistrust of healthcare or research, but mistrust of other institutions like, the police or government. And that can kind of, create a culture of general kind of mistrust, and people live in, maybe what are deemed to be kind of positions of power, and also views around research as being a social good. That's quite a key motivator, often for people, that they want to contribute to research, and feel that that's a beneficial thing they can do for sort of all of society. Quite an altruistic kind of perspective. But also there can be kind of taboo and stigma around research or particular healthcare conditions that might be being studied, and people's worry about whether they will, whether it's appropriate to share personal information, things about their communities, and also kind of historical issues around mistreatment and systematic racism as well, which as I was sort of talking about with particularly the cases in the US where Black people have been exploited, and those kind of memories have sort of passed down through generations, and then give a sort of a very negative view of research. So I'm going to move on to some of the preliminary findings from our focus groups with research delivery teams. And again, this is sort of thinking about this in those different contextual levels, but also the key themes that are coming out. So this quote, all these quotes are actually from Research Midwives. So this person said, they're talking about first generation women, and that they don't have that kind of trust in the NHS because they haven't been brought up with it. And so you need to try and build that relationship of trust with them before you start trying to get them to take part in a research study. And this research midwife is just talking a little bit about the process of sharing things about themselves, asking about their baby, trying to have that conversation more casually and build that relationship and trust before you then sort of introduce the idea of research. So I think it's interesting to think about the differences between first generation and second generation women, and how kind of issues of cultural sensitivity and cultural competence for staff might vary when you're interacting with first or second generation women, how familiar they are with the NHS, and how that kind of rolls over into the additional kind of, I suppose, complication of taking part in research. And then also the issue of trust, which is a key theme throughout. In this quote, the midwife is talking about the kind of importance of approaching women of different ethnicities in different ways. So they gave this particular example where they found that white British women would often sign up for studies quite quickly, kind of almost then and there. But Black women were saying they wanted to go away, they wanted to speak to their family, to really think about it, speak to their husband. And the more this research midwife kind of explored this, they found that actually, whilst a white woman was happy to get the information very quickly and consent straight away, with Black women, if they gave them the participant information leaflet and the consent form kind of a couple of weeks in advance, it gave them that time and that space to think about it, discuss it with whoever they needed to. And that led to higher engagement and recruitment levels. So again, it's trying to understand different kind of cultures, and being adaptable and flexible in order to facilitate that cultural sensitivity, and building a protocol, I suppose, around recruitment, which enables that flexibility to take place, and trying to understand the different social factors that might be impacting women's decisions around participation. So this next quote is talking about the translation of literature. And again, I think this is a kind of a theme that Christine covered, which was thinking about, finances and having the budget to translate or to have interpreters on a project who can try and facilitate participation for those for whom English may not be a first language. So this midwife was very aware that, there's often limited funding. If you can't translate the consent form or the participant information sheet, then that counts as someone being having to be excluded because they can't understand that information. And even if there was an interpreter there, or even if there was translated documents, can the research midwife actually then answer the questions without an interpreter as well, to make sure that that woman really fully understands what she's taking part in? And so, language barriers, accessible materials, and the burden that place on participants in particular, and trying to think about university kind of or research operations in terms of funding, and the ethical questions that raises around consent. And then this final quote is talking about a specific study, the Devo study. People might be familiar with it. This person was saying that at least half of Black women were declining to take part in this study. And then they spoke to their principal investigator, who was himself African, and he kind of enlightened some of the research team that there were these wider issues of distrust around data sharing because of historical practices and mistreatments around personal information, identities, fingerprints of Black people, and how they've been misused in the past. And that's kind of developed these issues of mistrust. And his interpretation around that this, as a result, Black people were less willing to take part in research because they were more suspicious of what was going to be happening to their data, how it might be used against them, potentially, or for purposes that are not that they're not sort of agreeing to. And so I suppose there's thoughts there around clear research material, so people understand exactly what their data will and won't be used to, but also trying to build trust that these practices are secure and that they won't be used in ways that they're not supposed to be. But the kind of institutionalized racism and suspicion around that. And again, that often comes more from an American context than a UK context. So I'm just going to finish with some concluding thoughts on our preliminary analysis so far. So preliminary themes from the review are kind of around mistrust, altruism and personal benefit of people taking part, the burdens of participation for individuals, knowledge awareness, and candidacy, which is about people's feeling that they are suitable candidates for research or for healthcare, and also interpersonal and social influences. And then I've tried to sort of start mapping how this also relates to the themes in the focus groups, which was similar but slightly different, around issues of cultural competency and sensitivity, building trust and utilizing existing relationships, with particularly recruiting, not just always using the research midwife to recruit, but also the midwife or the doctor that woman already has an existing relationship with can be a really great advocate because they've already got that trust in that relationship. And if that person says, oh, you should think about this study, then that can often be a great facilitator. And then the flexibility, adaptability, and creativity of research teams to adapt their practices to ways which fit the needs of Black women. And then what came through very strongly in the research delivery teams, focus groups, was a real lack of training or guidance and support to help them do this. There was often kind of general training around equality, diversity, and inclusivity, or cultural competency, that they had sort of generally as part of their jobs as healthcare professionals, but nothing specific to research in particular. And I think that's a real key area which we are hoping to contribute as we carry on with the study. But a lot of overlap between the research so far, and we're looking forward to doing our focus group soon with women and thinking about how the findings from those will fit in with these findings so far as well. So that's the end of my presentation for now. I just say thank you for listening, and if anyone is interested in getting involved in the study, then we have lots of PPI opportunities for healthcare professionals or for women to be involved in the project and contribute as we go along. But that's all for me for now. Thank you very much.
Gosh, that's super. Thank you, Georgia. That's fantastic. Goodness, I think that is really, I think it's very exciting to have a project that's kind of finished and then a project that's really on the way. It's very much research in action, and the things that I've taken away, these new, well, they're not new to you as researchers, but I know in midwifery it's quite a new thing, is this co-development of guidelines and co-development of projects and co-development of all sorts of things, which gives a much more power to women and their families, that came through very strongly. I've scribbled all over my bit of paper. I have got a question from Maria, and I know that I always say this is the quickest hour in the week, but we've stolen a bit of time from the next hour. So we've just got a little time for questions. And Maria's asking a question. Maria, who's a midwife, hi Maria, says, do you think engagement from Black and brown women would have improved if researchers from the same or similar diverse backgrounds discussed studies with them? And maybe I should direct that maybe to Georgia and Shireen first. I know, Christy, I don't know how your voice is holding up, but I'll start with Shireen and Georgia, maybe.
Yeah, so that was definitely my my thought when we started this project, that would be a really key factor. And when you look at the data in the review, often it's actually interesting that more than rather a similarity specifically between race or ethnicity, is actually just any kind of similarity. Often language is the most important thing. If a woman speaks a different language and she has a midwife who speaks that language, then that can be, an instant kind of bond. But it can also just be, it can be any similarity. It might, any sense of familiarity with that person. It might be race or ethnicity. It might be country of origin, language, gender. It might be, I don't know, having a similar accent if you're, in a particular part of the UK even, it might be like that person sounds like a Brummie and I'm a Brummie. So, that makes me trust them. It's any sort of sense of familiarity. But then when we did the focus groups with the research delivery teams who were mainly research midwives, actually their view was that it wasn't super important. Again, some of them kind of thought it might be, but when we spoke to Black research midwives, they felt that wasn't a factor for them, or the communities that they represented and the communities that they were trying to recruit. So it was mixed.
Because I recall Christine was talking about seeing people. Well, I think you both did actually, talking about seeing people like yourself doing the things and being involved was important.
If I can
Shireen,
add to
did you want
that,
to add something?
I was to say, so being from sort of an ethnic minority group, and again, as Georgia says, with the Promise study, we have just started sort of talking we've just started sort of recruiting, and we will be talking to mothers sort of from tomorrow, so we'll be able to say more whether that does make a difference. But another study that I am involved in, it's interviewing parents, majority mothers from ethnic minority groups, with children with neurodevelopmental disorder, and I think there, as Georgia says, that familiarity or that trust or building that relationship, which I think Christine also mentioned, I think that's really important. And for me, when I've spoken to parents, I do find that if you have got something similar, which might be your culture or your religion or those kind of things sometimes does help because it's that building that rapport initially, and I think that helps build that trust, which then helps them sort of, in terms of taking part in research, it then feels a little bit less scary, and they're more likely to take part. So I did find within that other study that having researchers in there who were from different ethnic minority groups did somewhat facilitate that engagement. Yeah, so that's sort of my experience.
I mean, it's good to, I would have to say it's good to have the community of midwives and researchers reflecting the community that we're serving and we're researching with, but it's not always possible to get that right. I mean, I thought when Christine mentioned something about it almost felt like some women who were being involved in the research was almost like a social connection tool. I don't know if you remember when you were talking about that, Christine, but it sounded as though it was a mechanism for women, and it's almost like women were receptive to being involved with research because it was a way of connecting with other women.
Well, I think that was probably particularly a feature of the group care trial because it was a social model and there was that group element. So obviously that did attract people. But if you look at the experience of previous trials, you'll often find that just being involved in a trial, even when you're in a control group, people perceive additional social support. So that contact with the research midwives and the researchers being asked about your experience, how it went, and so on. There's a dimension to that, and I think I just kind of echo what Georgia and Shireen said. We didn't pick up any indication that people needed somebody to be just like them, but I think it probably did matter that there was, diversity in the research midwives in the services. There was diversity in the research team, and also the collaboration with the bilingual health advocates was really, really valuable. So I think it's always a good principle. You want to see the diversity amongst the researchers as well, as a matter of principle, as well as, being a more kind of welcoming approach to doing the research and including people.
There definitely should be anyway. I mean, I think the other thing that I picked out from you, Christine, was the time element. And I mentioned it when you were finishing as well, that it's very difficult. And anyone who's watching now, who's thinking about doing a research project, and I think you can pick up some fantastic ideas from Christine, certainly. And also, when these guidelines come through, these co-produced guidelines, it's going to be fantastic. But there is a huge amount of planning that has to go into every project, no matter how big or small. And the time element is always drawn out because, especially if you've got funding from somewhere, the funding person gives you a timeline. And it's quite a tight timeline. And, obviously things went better in Christine's research and they had a little bit more time, and you obviously need it. And you made a lot of good use about it. But it's something to really think about if you're planning any research. And as well as time, of course, is money, because if everything's taking a lot longer, you need more money to pay people. And of course, you've got all these different payment issues like creches and like even, I mean, a £10 voucher, which isn't going to be the woman's sort of biggest reason for doing something, but it's part of the respect that you're paying her, isn't it? But it adds up if you've got 100 women. That's quite a big
2,000 in our case, yeah.
Yes, that's quite a commitment. So you have to sort of take that into consideration. I mean, I'm very conscious of the time, and I know that people have other commitments, and I'm very grateful to you all for spending your time, your evening with us. And is there anything you'd like to that you feel you didn't have the chance to say? Shireen should have a last word here as well about the project that you're doing, because it's very exciting, because tomorrow is going to be an exciting day as well. I mean, did you want to share anything with us?
Oh. I
Anything.
I think first of all, as I said, it was really interesting to hear about Christine's talk. And as you say, it's they've done the research. There's lots of things for us to maybe consider as well. So it's been really helpful and insightful. And then I think yes, again, as Georgia said, we've done the literature review, we've interviewed the research delivery team, and it'll be really interesting now for us to see where there are similarities between what the research delivery teams are saying and the mothers, but also what the differences might be. So hopefully, we'd love to share those findings again, in the near future. And thank you for giving us this opportunity to share our, preliminary research. But we look forward to telling you more, hopefully, in the next few months or so.
Fabulous, fabulous. Well, that's superb, because I was going to say this is just the beginning of your story, so we need the rest of the story. Now, I've got one final question I'm going to allow, and this is Natasha Hall. And excuse me, audience, I'm looking at my other screen. I'm trying not to be rude. And this is Natasha Hall. Hi, Natasha. It says, hello. I found it really interesting that Georgia has mentioned the concept of participants in research, seeing similarities to those conducting research and being potentially more receptive. Would you say most studies who utilize interpretation services in research utilize face-to-face interpreters for this reason? And I think that goes for Christine's and George's project. But George's, it was addressed initially to you.
I think so in terms of I suppose interpreters either on the phone or in person, the thing with interpreters that you hear a lot is that it does, of course, make the exchange very clunky, because you've got this other person in the room and everything's going to take longer. And often a problem with interpreters as well is that they aren't always trained in healthcare, particularly. They might just be an interpreter who speaks that language. And sometimes, particular medical jargon gets lost in translation. So there was one woman in particular who had an interpreter, and in her language, I can't remember what language she spoke, but in her language, the word for cervix was very similar to throat. And so she was being told her baby's going to come out of her throat, and she panicked. Thought, what on earth is happening? Lost in translation, because the person interpreting didn't realize that, that was an important distinction to make. And so I think on the whole, in-person interpretation is probably better. There's also obviously a lot of caution about family members interpreting and whether that is ethical or appropriate, and whether it should be someone who's independent as well. I think often on the phone it can be harder, because it's you haven't got those in-person like non-verbal cues. You can't pick up on the body language, and all those things are harder online or on the phone compared to if you do have people in person. But it's so hard for the NHS to get interpreters and to get them booked in advance and get them there in person. So there's practical challenges as well. I don't know what other people think.
I don't know, Christine, you're
lesson
so itching to say something.
The lesson for us, I think, along the same lines as Georgia, I think our reason for wanting to have in-person interpreters wherever possible was about the quality rather than similarity. It was to ensure the quality of the interpreting, and having a service is that is kind of based at the hospital and dedicated to it had the advantage that you had the chance to really interact with the team and for them to really be familiar with maternity services, understand, what's important in terms of research recruitment, understand the community and the women. It's so much better than telephone interpreting, but telephone interpreting can be a really useful backup for less common languages. So actually having that as your backup as well. But unfortunately, I don't think the additional benefits of having those kind of services are fully appreciated. because we experience these kind of services being reduced during the life of our project.
Well, I think I need to bring this to a close. As I always say, this is the fastest hour in the week, and we've had a little bit more time, but that's many apologies for our technical hitches. We don't often get the gremlins, but when they come, we have to make allowances for them. So thank you to our wonderful speakers, and Shireen as a speaker at the end. Thank you so much. Thank you also to Angela, who's behind the scenes making sure this is recorded and it'll be accessible to you over the next few days, and on that in that podcast on 6 o'clock on Friday morning. Next week we'll be here, same time, same place. And next week's also the Manchester Festival on the 8th of July. So there might be 1 or 2 places free. So if you haven't booked, do book and we can see you there. And in the meantime, again, thank you to our lovely speakers. Thank you to you for joining us, and take care of yourselves all, one and all.
Welcome to Matflix, video streaming from maternity experts. My name is Dr. Jenny Hall. I am the box sets curator at Matflix, a fellow of the Royal College of Midwives and a former editor of The Practicing Midwife. At Matflix, we bring together videos of talks from top maternity experts into box sets to support your continued professional development, study and revalidation. It is a perfect study accompaniment for midwives, maternity professionals, midwifery students and anyone thinking about a career in the maternity services. My job is bringing together the latest thinking area by area so you do not have to. Not only do you get the video of brilliant talks and relevant content in thematic box sets, you also get access to the audio version so you can listen on the commute or while you walk the dog. Plus links to the latest research in the relevant field, government policy documents, the presenter's PowerPoint and more besides. Sign up to Matflix now for the best video streaming from maternity experts.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers. And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators